Good evening, everybody, and once again, thank you for coming tonight. I should take my mask off, shouldn't I? Yes. All right. Well, listen, I do some work also at the New Zealand Brain Research Institute, and some of you who know me know that my kind of area of interest is in multiple sclerosis. So my talk today is just some of the work that we've been doing within multiple sclerosis, and particularly with respect to epidemiology, which is the area that I'm particularly interested in. So as I'm sure many of you know, MS is an inflammatory condition which affects the brain, spinal cord and optic nerve. And essentially what happens is that you get waves of immune cells that move from the periphery and then move into the brain and cause these pockets of inflammation, as you see here on the MRI scan. And we still don't know what causes those or what sets it off, but what we do know is that without treatment, repeated episodes of inflammatory waves then lead to damage within the brain, as you see here, and a damage to the networks that some of the others have been talking about, and ultimately lead to the disability that people experience with this condition. So what is it about epidemiology that's important, and why is it? Epidemiology is the study of the frequency and the pattern of disease in a population, using sort of robust scientific methods. And why is that important? Well, my mother thinks that cancer and dementia is going up, she's told me. Now, she might be right, but she's also just moved into a life facility, a care facility, and so it may just be that she's seeing more of it. And I think that probably none of us want my mother's hunches to decide what our healthcare system is going to do next year. So hence we need some robust methods. And I'm going to give you an example of how that can work. So in about 2006, we began to see more and more treatments for this condition, multiple sclerosis. Now, these treatments are very expensive, and of course our health providers were reluctant to spend all this money unless they could determine, one, how much it was going to cost them, and two, the kind of, whether they were going to help or not. And so at that stage we really didn't know how big the burden of disease for multiple sclerosis was in New Zealand. And so myself and Bruce Taylor, who's now in Tasmania, and a number of other people embarked in 2006 on a national prevalence study. We identified 2,917 people with MS at that time that were living with MS on Census Day 2006. And we were then able to get prevalence data. And you can see there that the prevalence in the population is about 72 per 100,000. And we also were able to confirm that in Maori, they seem to be much less and perhaps even protected from multiple sclerosis in some way. We also investigated the level of disability that people were experiencing with this condition. And you can see here that about 40% of people had fairly minimal symptoms. It might affect them a little bit, but not hugely impacting them. But 30% had relatively, difficulties with walking difficulties and other things. And then a further third or more actually had quite severe disease. So again, we could use this information to say a lot of people were experiencing a lot of disability, creating a lot of health burden for both the patients and for society, and we were able then to give Pharmac the kind of information they required to convince them that these medications were advantageous. The other thing about epidemiology is that you can then use the data to kind of compare yourself with other people and also with other diseases. And as you can see there in that diagram on the right, the data confirmed what we already suspected, and that was that little old New Zealand down the bottom there has quite a high prevalence of multiple sclerosis, similar to what you see in the UK and Europe and in North America and Canada. Now, the very astute amongst you will also notice that if you look at where the equator is, that the countries that are further away from the equator appear to have much higher rates of multiple sclerosis. And you can see on the diagram to my left that this is also true in our longitudinally extensive country, where rates were sort of, I think they're about 35 or something in Northland, and up to 135 per 100,000 in people within Southland and Otago. So this gives us information that then we can take forward and use in all sorts of different ways. Now, the good thing about doing one research project is that it can lead to other projects. And so this year we have been doing a mortality study, and Ruth Ledbetter from Wellington has been leading this with some help from Michael and Daniel who are here tonight. And what we did in this study is that we followed patients up 15 years after our 2006 study and looked at patients who had died amongst patients and were able to get some information. And you can see here that New Zealand being a small country, I can find you anywhere. And we were able to re-find 93% of patients that we had had in 2006, which is extraordinary, so you can't hide. Now, we found that 844 patients had died, about 30%. But that's not terribly meaningful just to know that, because you need to know how that compares with the general population. And so the graph on the right shows you survival. And again, this is where we use our robust statistics. And what we've done is we've compared there the New Zealand population, which you see in orange, with our MS cohort. And that shows that the survival is about 6 years less in people with multiple sclerosis than the general population. And interestingly, we found some old data from about the 1960s, and there may have been some slightly different methods used in that, but certainly nowadays, or what we found is that the median survival for people with MS is 46 years, so a long time, compared with sort of 16 years in the 1960s. Now, you can then use this data in lots of different ways, and what you can see here is that we can then kind of pull the data apart and we can look at how people with different genders, different types of MS are affected. And on the one side there you see the observed mortality, which is what we saw, and then what we would have expected had the person been in the general population. And what we do from that is that we get what we call standardised mortality ratios. And we can then use those, because they are standardised to the populations, to compare ourselves with other countries and other groups that have also gathered the same data. And you can see there that there was a large meta-analysis, and there's been some more done since then, which largely are from Danish and Canadian cohorts. But you can see that their standardised mortality rates are about 2.89. And so our rates still are quite favourable in terms of being very similar to other first world countries. And of course then you can use this data and look at health sort of inputs that we do, effects of treatment, and follow those up and track where our mortality moves and whether it improves. But also you can look at targeting particular groups. For example, it looks like people with PPMS are more disadvantaged, and so therefore we can look at health strategies directly related to those. So in summary, robust epidemiological data is really important for healthcare planning. It also allows us to assess health initiatives and particularly treatments. You know, treatments are expensive, and we want to be sure that they're working well for people. And it also gives us insights into the patterns of the disease, and it might help us in terms of understanding the causality of these conditions, which we still, you know, kind of fumbling in the dark with. So, all right, thank you very much, and I'm always happy to talk about MS afterwards.